Right there. We're not starting. See, it's interesting because
Yeah. Good afternoon, everyone.
Good afternoon.
I think we don't teach that directly here, but pick up on it. So welcome to Palmer. Thank you to our two faculty sponsors for the Palmer Research Symposium, and certainly our two students, Abigail and Rachel, who serve as co-chairs this year for Palmer. Not present with us today, but we're definitely grateful for them, are members of the Palmer family, who started this. We're in year 21 now, is that right? Or 22? Year 21 of the Palmer Research Symposium. Marty and Doug Palmer, both of whom have served on our board. Marty's currently on our board of directors. Their family has been incredibly supportive of us as an institution, and neither of them could be present with us today because of previously planned travels, and so we certainly do extend our appreciation to them in their absence. I am delighted to welcome to our campus a family friend and colleague, Dr. Amar Beatty. Dr. Beatty currently serves as the Associate Dean of Research and Associate Professor of Pharmacology at Lincoln Memorial University in their College of Dentistry in Chattanooga, Tennessee. Dr. Beatty completed his doctorate of dental surgery and his PhD both at the University of Tennessee Health Science Center. His career trajectory demonstrates exceptional growth and commitment to dental medicine and research. Early in Dr. Beatty's career, he practiced as a general dentist and an oral surgeon with expertise in oral surgery, general pediatric, and cosmetic dentistry. After working at the University of Tennessee College of Dentistry for several years in the departments of biosciences and general dentistry, Dr. Beatty joined Lincoln Memorial University College of Dental Medicine in January of 2023. His career took another significant step forward last year when he was promoted to Associate Dean of Research and Associate Professor of Pharmacology. So I want you to please join me in extending a warm Morningside welcome to Dr. Amar Beatty.
All right. Thank you, Dr. Mosley. Welcome, everyone. Thank you for being here. I might be sometimes fun to listen to, sometimes I'm bored. Okay? If I get boring, just tell me, move on. All right? So stop me at any point in the conversation because I actually have a principle. If I'm giving a lecture, I'll have objectives on that. I'll explain you what is expected for you to learn and what not to learn. Here, I'm just going to tell you a story, how I got my interest, and give some research background and how I got into that research perspective, giving about some information. If you can't hear me, let me know. I'll drink some more water and try to scream a little more. So, but that's basically that. Hopefully this works as well. I have actually took a topic which is part of my cannabis science background and pharmacology, pharmaceutical science background, and it's pertinent to today's society. We have a lot of problems currently happening, challenges happening, because we do not know what dosage, what concepts to use with cannabis. We used to smoke it, now there's edibles, there's different things outside there. So I thought I took a different approach this time. I said, hey, all we talk about is bad, and I'm going to talk about that now, okay? Because there is significant contributions. I will start with one thing that I teach all my dental students as well. All drugs are poisonous, period, unless used therapeutically, right? So there's dosing parameters, there's abilities where we use and how we use it. So when someone says it's okay because everyone else is doing it, we're not challenging them here. mean, it's just being comfortable in your shoes. So I took upon this journey to kind of elucidate some areas which are confusing for others, but I'll tell you my journey of how I got where I got. Okay, so my lecture today is going to be cannabinoids, about oral health, because that's my specialty. I do activate and talk about systemic health in between as well. And we are talking about therapeutic potentials, but of course, with therapy, there's always the negative that you have to understand the adverse effects, the consequences that exist. Okay, so let's see if I can get it. I'll move from here. All right. So I'll stay here for now, and I like to move a little bit because I like to read the audience and how much to pace myself, right? So, all right. So I'm going to tell you a quick story about myself. I was born in Hawaii. My father did his PhD there in political science, and then we moved to Pakistan, which is my family's from. Stayed there for about 6 years, second grade to sixth grade approximately, completed all that. Came back to the U.S., Atlanta, St. Louis, but home was Memphis. So all my high school was Memphis, all my college was Memphis, and until recently I left Memphis. So that's where it is. It's also home to Elvis Presley. So if you guys want to go there and you like the King of Rock and you like Graceland, you can go there. He has fancy clothes, I promise you. That is definitely there. All right, so education. You did a little bit of introduction. I'll give back. I'm a University of Memphis graduate, locally from the University of Memphis there. At that time when I was there, we almost won the national title for the NCAA tournament. Fun fact, I was also the tutor for the athletics at that time. It was because of me. All right, so I went to College of Dentistry over in Memphis, University of Tennessee Health Science Center. Got into a dual degree program. So I did my PhD and DDS together. I had to find a mentor for PhD, as we always do. The College of Pharmacy, and then his name was Dr. Bob Moore. He was a medicinal chemist who didn't want me to be a full-on pharmaceutical science guy. He wanted me to do more of pharmacology. So because we were trying to decipher cannabinoid science there. So that's where I learned my cannabis science. And again, my alma mater becomes University of Tennessee. Although I'm technically competing against them in the state now. So it's about dentistry, okay? So, all right. So, let's see, did I miss it? Okay, I want you to just, as I go through, because at times I lapse, I want to explain this before I move into my talk. So, let's see if I have a laser. I'll try to see if that works. Does it? No? There we go. That's the wrong button. Okay. So, cannabinoids, generally or termed from something that comes out of the cannabis plant, right? Because cannabis sativa, which is the most common one in our North American, South American region, the plant itself. The word cannabinoids mean things that are coming out of that plant. Now the term is much larger because you actually have synthetic cannabinoids, meaning we produce them. We targeted the endocannabinoid system. We can have phytocannabinoids. Phyto terms with plants, so therefore it's phytocannabinoids. And then we have another thing called endogenous cannabinoids. So we produce them. Right, so remember this part of life sciences. You use an opioid or so, we have the receptors. Our body produces natural, for instance, enkephalins or endorphins that we're actually activating that receptor. Same thing exists. We have come to understanding about this endocannabinoid system. It's quite large. It plays a role throughout the body. There's significant distribution changes that exist. I do not want to go into that at this point, but I just want to let you know our body is able to produce some type of cannabinoids ourselves, which we call endocannabinoids. I'm going to name them out for you. One is anandamide, and the other one we call 2-arachidonoglycerol, right? So we call it 2-AG because it's a mouthful. The anandamide was found, just for a fun fact for you guys. So the guy who actually found anandamide was also profoundly interested in yoga and other things of that sort. So he actually found the word anandamide, described it from Sanskrit, which is an old Hindu language, if you will. Ananda, or Ananda is what you pronounce it. Ananda basically means something that's blissful. That's finding the bliss. So they found anandamide, which is a bliss molecule. So that's what they did. So that's what they named it, and that's what gets you happy as well. So THC, which I'm sure many of y'all know, many times if it does make you happy, other than giving you a trip or something, it probably uses the same type of mechanistic effects that does anandamide. Okay, so, wait 1 second. Okay, I'm going to move forward 1 second, and I'll move back afterwards. So, in this pathway academia, I tried to go out and work as a dentist, but it turns out that people kept on reaching back and saying, you have to do this, you have this, and I felt for the travel. So I stayed in academia. Could have made much more money, but so but we got into this, and I actually ended up publishing a lot of work that is currently also being reviewed currently with oral surgery and other types of fields that we're trying to make sure we understand what we can do for the oral cavity and what it impacts when we do tooth extraction and things of that sort. And that's where I'm going to start to stay around and try to make sure you understand the positive more than the negative. But I'm going to start with the negative because it's important to first make you understand what the adverse effects will be. Okay, so this is where and I want to just do a shout out. I actually got in also in the program, which was Free Health Scholars program, where I have a picture here. This is from UT. I'm actually expressing to the faculty as well as the students and what dentistry is about. So this is for underserved communities and so on. So we actually have a program to improve there. So Dr. McTavish was one of the leads with me on there who we did this program for. All right, so just moving on 1 step forward. This is my current crew. There's actually more people around. I won an award recently for Colgate. I think they want some recipe. I'm not going to give it to them. But anyway, so we did a research subject there, but we actually have a crew of scientists around me now at LMU. I helped develop that whole program with one of my friends, and we actually have a bunch of friends together, which is very fun to have because we bicker like little children, but we don't get mad at each other. So, but that's the science part. We publish a lot of different things. Our main core right now for LMU is the oral systemic health connection, in which we are looking at short-chain fatty acids, microbial life and impact to the body, as well as cannabinoids, which is my expertise there. All right, let's move back for a second. Now, let's go back to my journey, and as we talk about the holistic journey, I have to get you back to the importance of cannabis itself. Now, there are 3 plant types. I'm not going to get into the whole schematics of what is where and exactly where it's found, but generally speaking, cannabis indica is normally found in India, the word indica, so that general area is pronounced cannabis indica. The other one is cannabis sativa, which is found in our area, right? And then there is cannabis ruderalis, which basically, to my knowledge, what happened is when they found that the hot peppermints were producing THC and other medicinal use, they tried to take the plant to Europe. It was not the same plant. The plant kind of changed. So many of the things in Western history and so on, that's why it wasn't used as much. Because they were like, hey, there were working properties there, but it's not good in that European area, so we kind of let it go. So I'm going to go back on the ancient China. So China, they started using for surgical perspective. So the first anesthetic for surgery was a mixture between wine, because you have to get drunk first, and then you kind of give this cannabis perspective. And they actually had surgical perspective there. Same time, India, you have Ayurvedic medicine, holistic type of medication concepts, and they actually have cannabis as a tincture and other forms. Remember, when we were using these medications before, they would kind of like make this plant like a resin almost. They kind of squeeze it down, put them in alcohol, or make some type of tinctures. And then we'll give some kind of oil directly into the ear, so the ear area, or give it sublingually to give that pain. So that's what happens in India. They actually also use it for religious rites. Has anyone participated in a color run ever? You're familiar with a color run, right? So it comes from the concept of Holi, which is a tradition in India practice. They actually drink this, I'll call it milkshake for the sake of it. It actually has cannabis indica in it. So they actually do it, and it's supposed to be cleansing for them and kind of getting them through this means that we can all enjoy different colors together and be high while we're at it, right? But technically, it's a spiritual journey for them in terms of that. I find this fascinating because these are historical records that we have, and we kind of don't discuss it as much. It's fun to have the history. Persian culture at that time, before pre-Iran, if you will, what they have there was a famous guy named Rostam, who was like this big fighter that they know about. His head was too big. His mom couldn't give birth to him. So they actually used camphor and a mixture of cannabis as a form to help the baby come out. So basically that was intriguing there. In Islamic medicine, it was used for epilepsy, tumors, various skin diseases. So in Baghdad, when that was the main area of excellence of science, they actually used that as a various form. And notably, understand this, the cannabinoids themselves are not really found much in the male plant whatsoever. It's the female plant that has a flowering capacity, and then the bud is the primary area of this cannabinoid form. Okay? So generally, that's the overlap. So all of a sudden, as I mentioned to you, we have a condition that happens is you actually have some effect going on. There is Dr. Sir Williams O'Shaughnessy, hopefully I pronounced it right, Irish scientist. He in the 1800s brought it to Europe only for it to work from the actual tinctures that he brought. For it to grow the plant, it didn't grow well. So it kind of got lost in the Western civilization. Not to the 20th century, we come back in. I'm going to talk about more of the negatives and the positives over here because what happens is before we used to have this product and people were getting information from it. So what they end up doing is 1937, they start to put taxation on it, right? So before that, the pharmacopoeia, meaning the pharmacies, had tinctures of cannabis available for natural treatment. But 37, they started taxing the area. 1970, they put it under Controlled Substance Act. This is where the drug wars are going on, shut down of all these things. And then you also have all of a sudden it being done in Schedule 1. So ones who do not know what schedule the DEA schedule is, DEA Schedule 1 basically means it is of no, it's high abuse potential, no true therapeutic use, right? That's the principal idea behind it. So then what happens in 1985, which I find fascinating, they produce a drug named Marinol, and they synthetically drive THC. So basically what it is synthetically driven. I made my THC, and I'm now selling it as a drug. Starts out as Schedule 2, 10 years later it becomes a Schedule 3. And Schedule 3 basically means that you don't have that much addiction potential to it. It does have it still. So basically some of your, depends on what it is, but some of your benzodiazepines and so on, like Valium and so on, are in that Schedule 3 range, right? So that's generally what you have. In that sentiment, we are basically in 1988 to 93, we find the receptors and find the endogenous ligands that are needed for us to work this system, the endocannabinoid system, right? Again, I mentioned to you the endocannabinoid system works through a whole bunch of different areas in your body. It's with metabolism, it is with hunger. Y'all know this is hunger because y'all get the munchies, not y'all, but people who use it get the munchies, right? So the general idea is that's what's happening there. So there is a significant, it's lipid in nature, fatty, so it's also in a lot of overlap in that. That's why individuals who consume it through different routes, such as edibles, sometimes have an event that takes much longer to happen, because by the time it goes in your body, it probably stores itself in your fat. And when you're sitting down and just relaxing, when that fat's starting to burn, it probably releases those molecules into the bloodstream, and then you get the high or whatever the effect was. So that's why there is a problem with the route you take it. 2018 caused a little of a conundrum for us as well. They separated the concepts of marijuana and hemp. Hemp was described anything by 0.3% of THC, delta 9 THC in it. So anything below that 0.3 or below is all hemp. It's the same plant, cannabis sativa. Anything above that became that. Now, all states could technically use CBD. And one of the things that you see nowadays is there like Delta 8 available on the market here, right? What they end up doing is the way they bypass this whole thing is you can take cannabidiol, which comes from hemp, and they transfer it chemically and make it Delta 8. Because Delta 9 is written, 9 by name is written that it's not permissible. So therefore Delta 8 is permissible. Technically it's not, it also gets you high. But because you use the hemp route, you can bypass that. Because you can use that, what is permissible, to use around in the industry. All right, so I'm going to go back to the receptor system, which now we talk about the endocannabinoid system. There are several putative receptors that I'm not going to talk about. I will talk about two receptor systems that's worthy of knowing, and if you guys want to understand it, it's the easiest it will go through. Understand cannabinoid type 1 receptor and cannabinoid type 2 receptor. If I ever talk about getting high for direct pain modulation, basically impeding the CNS, that's what I'm talking about. CB1 is highly prevalent in your CNS and your brain, basically your brain and your spinal cord. That's where it's primarily at, so that's where it gets you high. CB2 is found primarily on your peripheral cells, markedly at the immune cells. Because whenever I'm going to talk about immune response, I'm going to be modulating that receptor, right? Compared to when I'm talking about getting high, it's more primarily associated with the CB1 receptor. So just food for thought. Okay, let's go back to dentistry because that's what it's important. Now, if you look at the literature, and when we see patients, we know for a fact that individuals who are smoking or using cannabis, they actually show more decay on their teeth. They actually do have higher plaque index compared to non-users. And so there seems to be some type of regimen that they actually are doing, which is leading them to having worsened oral health, okay? And on top, there are documented cases, generally with smoking, just understand this, because we don't know at this point what the cause and effect, but no smoking causes oral cancers. Smoking one or the other, the details are not there, because people who are smoking marijuana might most times smoke other things as well. So there's like a holistic sentiment there. So, but generally, they have seen xeristomia means dry mouth, right? So people, not you guys, people who smoke, right? They will get the cotton mouth, or the drying of the mouth. There is tongue cancer that's there. You will see inflammation of the uvula at times that's present there. You will see tears at tongue. This means a lot like hot red, like cinnamon-like. Gingival tongue that you're seeing on the So these are things that are clinical implications. The other interesting part was when they've done case studies, they found the most prominent areas that get affected are the lower mandibular anteriors, so in the front area. It makes sense because if you think about it, number one is normally we're standing or sitting down, gravity is this way. When you smoke, people put the butt between the anterior teeth, right there, and they smoke. The smoke actually comes down and stays around the lower areas, whereas most problematic for them. So majority of them, if you all come to me, I'm not saying it, I could potentially look from your mouth and be able to kind of determine if you're not only a smoker but also a marijuana smoker. So just FYI. So there are keys there to look at. If you all get to dental school, we'll teach you it. So so general idea is that. Now the problem comes to being is we as dentists are concerned because we know it impairs immune response. Because people who smoke chronically use it. There's a problem in terms of that. There is, because it affects also bacterial population, there's also a concern there that comes with it. So let me holistically put it for you in a problem of the usage. The problem emerges, we know that it is anti-inflammatory. If you're a healthy individual and you use like assume you're using ibuprofen for no reason, right? That actually compromises your immune response. Because there's no reason for me to use that. Because my natural body and the system is working properly. So in that sentiment, this is just kind of giving you that anti-inflammatory response locally. We know it ends up killing certain of your gum cells. So you end up having cytotoxic effects on cell types. Then you can also have certain types of bacteria being affected. Now, in this case, I don't know which bacteria is being affected, but I will tell you the following. If you take the holistic concept of the gut or the mouth, we talk about good bacteria and bad bacteria. I don't want to go into the details of those because that's a very arbitrary thing to talk about. The idea comes to being is the good bacteria can potentially get killed. So the prominence and that leading to microbial dysbiosis is the term we call. That means the bad bacteria can propagate and cause damage in terms of that. Meanwhile, let's talk about the decay and the plaque. All of you know people who smoke get munchies. Right? What else happens? You get sleepy. And what are you trying to munch? High sugary, high fatty diet. It's a hedonistic desire that gets activated. I want to have something that tastes wonderful to me. So I'm going to do that. So and then you're getting cotton mouth, dry mouth with it. That's a disaster for your mouth because you're most likely not taking care of your mouth at that time. Because you're like, I'm going to eat this, I'm going to do it, I'm going to pass out. So technically, if someone is meticulous in their oral health care, it may not happen because there's a secondary effects that are taking place. But the reality is, we are the ones who are using it at that moment don't actively think about that. So there is that point. all this stuff, I'm going to go with some studies that I was involved with and giving you an overlap. So this is generally a healthy mouth. I tried to reduce the images for you guys. I don't know how strong of a stomach everyone has. I have seen people throw up before, and dental students. So I'm like, what are you all doing? But it is what it is. So we have, as we propagate, and as I mentioned, there's more plaque, there's more development. More bacteria as it comes through, our body tries to fight it back. Natural response to the innate immune response. But when it tries to fight you down, you have bacterial byproducts that the body picks up, which is, let's say, lipopolysaccharide, LPS. It picks it up, it starts to fight it through, and at one point it can resolve. But if you keep on having the same gunk over and over, at some point the body is going to be chronically activated. It's going to continue on doing it, and what you end up initially have is you're going to have these macrophages, for instance, pick up as antigen-presenting cells, release cytokines, chemokines, which are signal molecules to recruit more immune cells, right? So the idea would be the fibroblast then will pick that up, and then eventually also produce cyclooxygenase 2, which is upregulated. Y'all are familiar with prostaglandins? Okay, so generally speaking, prostaglandins, PGE2 specifically, is known to cause sensitization of the sensory neurons. That's why you feel pain, right? So the general idea is eventually you will feel pain, and forward propagation means that you will just have these matrix metallius proteinases break down collagen, if you will. So you're going to have gingival attachment loss, things of that sort happening. And then destruction happens in terms of that. So you lose at some point this mechanism. At one point where it becomes chronic, it becomes naturally pro-inflammatory, right? The homeostasis is lost, and we're in that state altogether. So in that same sentiment, sometimes the beauty of structure-activity relations comes into play. Have you all heard of this phenytoin medication? Okay, so it's anticonvulsant, right? Interesting part is when you give this medication, one of the side effects is gingival hyperplasia, meaning your gums start to grow rapidly. This structure actually is very similar to CBD in a structure-activity relationship. Turns out CBD also can cause gingival hyperplasia. So some of the things that I was reporting before, we don't have any direct evidence of this, but the literature does support that most likely it's happening. But now, cannabinoids in a cannabis plant are like 140 plus, right? So we're trying to decipher which one may be doing what. So selective modulation is important for what you do. So going to the overall sentiment here. So I have my endogenous cannabinoids that can bind to the cannabinoid receptor, phytocannabinoids, plant-based or synthetic. They will basically come in. Now, imagine something else for 1 second. Imagine if I am already inflamed. What if my body has already gotten the inflammation present, rather than me using marijuana to cause it? Let's just assume my natural diet, my natural habits have led to inflammatory propagation in my body, right? We have diets that lead to it. We have habits that lead to it. The more we're becoming more and more sedentary, we love watching Netflix, right? I'm also part of that behavior. So just saying, not being a hypocrite, just announcing the truth. So the point comes to being here is we continue on, if the inflammation is already there, can I stop the inflammation? And in this case, many times we use ibuprofen for typical pain issues and stuff, right? Because you get a cut, initially the cuts can happen is that the concept of inflammation is by the time the scab happens, you start seeing the redding concept around, that's the edematous tissue that was brought in by the immune response. And when you press it, you're causing the movement of those fluids, eventually desensitizes the nerves, and that's when you feel pain. So that's basically what's happening. Generally, they're easily activating that system. Now, what do we do here? We basically can, literature is supporting the concept of saying, I have all that is needed, maybe at that time. Okay. I have all this information that I can actually stop the inflammation itself. Because there is a pathway, hallmark, holy grail, if you want to call it, of inflammation. We call it NF-kappa B. It's a gene sequence. It actually reduces the production of it, therefore it can reduce inflammation. So studies are there. They're also supporting the idea that we can use specific medications to improve bone health, recovery. So even for osteoporosis, because there's receptors there that we can selectively target to improve that. Okay. So now what I'm doing is I'm not taking the whole substrate, right? Because I don't want 140 of these components. I want to as minimize as possible, and I'm going to do targeted therapy, right? So I'm going to use either CB1 or CB2. Again, if I'm modulating immune response, I'm talking about CB2, this type 2 receptor, right? focusing on, and that's what I did. We found a lead drug that works really well as an anti-inflammatory mechanism. We call it SMM189. Nothing fancy. That was a person, Sunni Mustafa was her name, who produced it, and it was the page number 189 of the synthesis. That's how we made it. All right. So it's nothing. It's not a fancy name. All right. So I'm going to go with an overview of some of the studies that I did. General idea is this: I can actually go into my patients and get healthy human gingival fibroblasts. Just get a piece of the gum. So we do our regimen and get that. I can also do it with periodontal ligament, meaning I can take the tooth out because the ligaments between the teeth and the bone. So from the tooth out, I can scrape that tissue and kind of get my ligament tissue from there, and then make that. But what I ended up doing was to normalize, because whenever you do this, you have to validate everything. Right. I had validated, but I was like, you know what? If I'm to publish this, I'm not gonna waste all this effort. I found an ATCC and Monza, two companies that were selling that. I was like, you know what? They've already validated it. I'm just gonna buy it. Right. So I ended up buying it, and I ended up studying several different pieces. I studied the selective modulation. I studied basically CBD, cannabidiol, CBDVN, or I'm going to call it CBDVN at this point, and cannabidiol, CBG. All are part of non-psychotropic cannabinoids, right? So I used those, and I looked at the cellular dehydrogenase activity, meaning we can study proliferation of cell death based on it. We looked at the immune assay, looking at what responses were seen if we made them pro-inflammatory in nature. We looked at other means of prostaglandins. I wanted to see how prostaglandins being affected. Do I reduce it? Do I propagate it? And things of that sort. All right. So I went through it. I went back to the literature. So remember, there's always, whenever you do this stuff as a scientific perspective, you have to help develop a model. Okay. So I can use many different types. So I can use LPS. I can use different cytokines, chemokines to cause my cells to react like it was inflamed, right? But the point comes to being is you have to do your due diligence to understand which cytokine is best associated with that. So it turns out that, in this case, I don't know if you can see well enough, but I'm just going to go with one. There was many other ones there, but this one is prominent in all of them. So severe periodontitis, the oral disease, we see IL-1 beta, interleukin-1 beta, being the problem in all of them. So I use that as a model because it was the best one to give, because it shows chronic periodontal disease, periodontitis. So the difference between the two is, as the body and healthy gums are here, you have your bones, you have your gums, and eventually clot and these pockets start to happen. You see bone being degraded here, so this tissue starts to detach. As it detaches, you have more bacteria going in, and this is where the concern comes in, because this area is highly vascular, and if you have bacteria and so on, and you have bad oral hygiene or oral health, you're having systemic disease, because these little areas, which are fenestrated blood vessels, will propagate and let through a lot of bacterial components, and that leads to subclinical infection. So many of these people, and I think there's a lot of nursing here, one of the concepts comes to being is like infective endocarditis, for instance. One of the primary bacteria there is coming from your mouth. Okay, so that's generally what we're going with, the strep species that we're talking about. All right, so now understanding the mechanism, so I use fibroblasts, and for a reason I use it, because we actually were able to also define in our papers that if you have one macrophage to it, majority of the tissue around, or the cell types around the fibroblasts, these work as antennas. So if you have one response coming through, the fibroblasts will increase more and more of that response to proliferate the inflammatory response, get more immune cells to the site of. Okay, so that's basically what we ended up doing, and we ended up getting these principles. All right, so look at the appreciative. I don't know if you can see it well enough. I can kind of see it, maybe not. Generally, so just believe me when I'm saying. There's spindle rod-like shapes here. LPS, there's more granular formation inside, and then you see a widening of areas going through. When you use something like anandamide, they start to proliferate. They start to increase their production of the fibroblasts, so there's a higher amount. If you use the drug that I was mentioning, which is a CD2 inverse agonist, it uses, with LPS, it actually recovers some of, again, you can't see as well up here, but the cells become more thickened, much nicer. It looks like they're healthy. So just giving you morphological changes in terms of that, giving you a quick experimental design. I'm hoping I'm not boring you all, but I'll try to move this as conveniently as possible. So basically, you're taking your cells, putting in your petri dish, 96-volt plate, 48-volt plate, whatever it may be. You're treating them with alpha and beta to cause them to become pro-inflammatory. So the way I treated was, I didn't want to co-treat the concept. I wanted to have disease first, and then treat with cannabinoids. So I did 1 hour treatment with the alpha and beta, caused the cells to be inflamed, and then 23 hours it remained with the cannabinoids of choice, right? So that's a general principle. What happens, we can take the media, what we call the conditioned media, the supernatant, whatever you want to call it. You can remove that from the cells. You can use these cells and do microscopy, stain them, fix them, whatever you want. That media will already have now all these cytokines, chemokines, because remember what I was mentioning to you is whenever you give an inflammatory signal, what do these fibroblasts do? They amplify the response. So they're going to start to shoot out all these cytokine chemokines everywhere. So in your media, you have a lot of this information already present. So I won't go into this because I'm going to talk about some electrochemiluminescence, which is how we do. All I'm doing is when I put it in this plate, which is pre-coated with the analytes that I'm looking for, by the time the machine sees it, it's actually seen as photons. So I'm actually getting very sensitive data. Each first thing is being responsive as a photon. If you all are interested in what that is, I'll explain to you a different way. Not for now. So, all right. So what in my publication we found was, and this is where I'm connecting the oral and systemic disease, we did 40 different types of analytes, right? Cytokines, chemokines, angiogenic factors, things of that sort. 18 of them were upregulated with alpha and beta, showing inflammation, and there's a direct response of it. Now in that, I actually started to put a proposal down together in periodontal, PD, periodontal disease. I found all these to be upregulated with alpha and beta. It turns out all these have a significant contribution to other disease that are found systemically. So I'm trying to connect the dots and also say, hey, if I'm doing this locally, how does that impact, systemically? And there is an overlap there. Information is there again. These are things that we worked on, and I'm going to move on, published in Journal of Periodontal Research. And just to show you a few pieces of that data, I'll just make it easier instead of seeing all of them. Just look at this TNF alpha. So TNF alpha, for instance, when I had control, there was basically no response. When I gave alpha and beta treatment, you see about, this is picograms per mil, there's significant increase from control levels. That means the inflammation had caused that to increase with alpha and beta. Now, I'm going to jump on the SMM. When I gave the SMM with the alpha and beta, because alpha and beta has to be maintained in it, we were able to rescue or recover close to control levels. There was significant reduction. Anandamide, however, is confusing. At some points, it shows pro-inflammatory responses, and some it shows anti. If I have LPS as a stimulator, anandamide is anti-inflammatory. If I put a chronic indicator, which is alpha and beta, it actually promotes it. So it's like a confusing tale, because you're like, hey, maybe I can explain that at one point, why it may be, but at this point, just the tale is false. So, but I continue on pursuing it. What I understood was I can selectively modulate with SMM. This is my proof of concept study that I can actually take a cannabinoid, have inflammation present in our fibroblastic cells, gingival or periodontal fibroblasts. I can then recover it almost all the control levels because this is a very good potent anti-inflammatory. Now, in this case, within this study, 18 the markers that upregulated alpha and beta, I rescued all of them with SMM. Anandamide, there was a toying perspective. There was the endogenous component. We believe anandamide naturally for you also works as an anti-inflammatory mechanism, but I don't think it works well in a chronic condition. Right? It just kind of doesn't do much what we need to. All right. So, with that being said, inflammation is associated with pain. Right? It turns out that breakdown process of anandamide becomes arachidonic acid and ethanolamide. And we know arachidonic acid, if you all remember this at all, goes through the cyclooxygenase pathway and produces prostaglandins or thromboxans or glucosamine, depending on what pathway it's taking. Right? So the idea comes to being here is, what this turns out that we actually were able to find that CBD, CBN, and CBN, which is kind of general, all actually are also substrates for COX enzyme. That means they actually have an overlap in terms of that. So if that's the case, can I study it for pain management? And so number two is, I have to do a proof of concept again, because earlier on I used a selective cannabinoid to modulate CB2 receptors. But if I show this work, I have to do the same thing, making sure that we are able to reduce inflammatory cytokines prior to me looking at prostaglandin levels. So I have to do the same proof of concept. So I published 2 studies. I got called at this is a page of the journal. They put me on the face of the journal, which is really nice. So I got this perspective, and I produced extension to that study, which I'm going to just give you quick highlights on. So again, I'm going to use TNF alpha in this case. As you can see, alpha and beta significantly increase it, and these are gingival fibroblasts rather than peritonial. That's why the difference in the protein concentration seems like gingival fibroblasts react much higher compared to the peridontal ones. And we are seeing all of them significantly reduce TNF alpha. What is the significance of TNF alpha? If you have this upregulated in your body, be it outside or peripherally, you have bone loss. There's degradation of bone, right? So it's involved in breaking down the bone, and periodontal disease, you're trying to save that bone, so you can save that too, right? So that's the general idea back there. So we started to look at these combos, and interestingly part is, have you all heard of the term IL-10? So we loosely describe pro-inflammatory cytokines and anti-inflammatory cytokines. IL-10 is a pro-resolution, meaning resolving the idea of inflammation, or anti-inflammatory cytokine. It turns out they actually increase that cytokine, meaning promoting more of anti-inflammatory mechanism, also through the endogenous system, right? So that's basically what they're doing in terms of that. So when you look at the prostaglandin levels, so you can see arachidonic acid of itself shoots it up, alpha beta shoots it up, again, picograms per mil, concentration of prostaglandin T2 levels, and you can see at 1 microgram per ml, CBD is cytotoxic to the cells. That's why we didn't see much of a response here. When I did a dose study, I actually found it to also be reducing prostaglandin levels. Here at 1 microgram per ml, both of them significantly reduced prostaglandins. I had an internal control, indomethacin, which is an NSAID, and it can actually also reduce all that. So basically, what I'm trying to get at is we can actually do that. So we are now, in terms of pathway management, I'm examining this whole pathway, cyclooxygenase, and the production of 2-AG and anandamide, and how it affects that whole pathway in pain management. All right, publication of after doing that, I made another publication happen. I went, and you guys can want to read it, you're more welcome to. This whole publication is all about what I have learned so far, the metabolic pathways, how to improve oral health, what they help with, what it cannot. The idea here is, if you're already inflamed and there's a polymicrobial biofilm existing, and we're trying to get rid of that and we clean it up as a hygiene aspect. As an adjunct therapy to improve gingival health, you can actually use something like the hemp oils, right? Because they actually have significant things in there, so they will reduce these cytokines, chemokines, and this application of these cannabinoids and the natural terpenes and flavonoids that exist within the hemp oil can potentially improve collagen and other formations as well. In terms of all theoretically speaking, I have specific molecules I have worked with to show CBD does actually cause an increase in collagen production depending on the type of cell you have, right, or area of it. So there are things of that sort that can happen. Again, everything has to be within dosing parameters, which is where it gets a little more confusing, how much it takes to do what. Like for instance, I laugh at this part. A lot of people ask me, they tell me they're taking collagen, for instance, for their health, because they want to improve their bones and things of that sort. For me, it becomes a problem, because I'm like, hey, if you take collagen orally, it's going to break down the peptides and amino acids. How is it going to affect that when I don't know it's going to affect that? Because it's not like you're putting it topically. So if you're putting a dermal area, I understand that. They probably supplements direct collagen. So it matters in how you're taking it, how much you're taking it. I know we have influencers and fads that go around, people just follow them blindly. Some things don't logically make sense. But that's not to say they cannot, but logically at times they're like, yeah, this probably doesn't work. So let's do one human study. I don't know, where am I at the time? Okay, I have 7 minutes. So I'll stop afterwards. All right, this is going to be more fun. This is a patient study that we did. So I use CBD as a form of a pain management here. So the whole design here is if I remove a tooth, simple extraction, let's say it's a simple tooth removal, for me, a simple tooth removal. So we will then decide that to be that, and then we will give as pain management, give treatment as usual, we'll give placebo, we'll give different dosing of CBD. This was done at University of Tennessee. I had my Dr. Karen Deripenko, who actually is a psychologist. So she used the help when putting that thing together for me. So, because all the write-ups was done by her. So I just did the clinical part. So anyway, so I have, the first thing we have to do is, when we give an oil, in this case we wanted to give them sublingual oil, right? Our concern was if you take it internally, edibles or so, we don't know the distribution pattern. The pharmacokinetics are all over the board. So we don't know how well it's going to do, what it's going to do. The point that we make at this moment is, can we do it locally on it? If we do it on it, we have this problem, something called dry socket, right? Which is a very painful event. We don't want to dry the area out, nor do we cause that inflammation present. So we decided to go sublingual with the oils that we will use. Okay, that was the concept there. Validating it from the certificate analysis, making sure it was all CBD. So there's nothing else in the detectable range. It's only CBD. All right. So we then calculated the dosing parameters. I went backwards, sorry. So these are the 4 groups that we made. High dosing, which is 37 milligrams per ml. Then the low dosing was 17. And so we produced in the way that if you make a dropper, it takes about 1 millimeter out. And you put it down, that's what you're giving them. We made a placebo event, almond oil and peppermint. We kind of put peppermint here as well, just to mask, so we don't have smell distribution and so on. But the general idea was, this group was a concern. Why? Because as a practitioner, I don't want someone being in pain. So when we made that, we also gave them basically blister packs. We said, hey, if you are, we actually gave blister packs to everybody, because we don't want to expose someone who's part of that. But if you're feeling too much pain, right, and you can't regulate it, and this oil is not helping, just go ahead and do the treatment as usual, which is the 4th. So there was a group that was also given ibuprofen and Tylenol combination. So we basically gave them that concept altogether. Meanwhile, I want to remind you all, pain is very arbitrary and it is subjective. Me asking someone how something was painful an hour or a day ago, they can't describe it. It would be 5, because the day of I asked you, hey, what was your pain level? It was 7. Next day, someone else asks you, I don't think it was a 5. And it becomes arbitrary because what today you're feeling or how happy you are and things. So what we ended up doing was, we had this thing called ecological monitoring. We actually got people who were recruited part of the study, we made sure they had a phone and had a text message capacity. So every 2 to 3 hours, from 9 a.m. to 9 p.m., they will get text messages for 3 days after extracting the tooth. So they're at the moment of, they knew exactly how much pain they were in, right? So that's basically what we decided to do. Once that was done, and there was a push to text, pretty much straightforward FileMaker, we told the patients, hey, we need a follow-up. And guess what? Compliance is always an issue. What do? We incentivize. You start the study, I got you $25. You come back a week later, I'll give you another $25. So they were happy, and they came back. And I actually, on my text rate, surprisingly, was at 81% response. It was a significant response. So that was that. The study included about 24 individuals with smaller groups. We have a larger study done. I can't show the data yet because it's still in statistics, like Biostats has it, so they're fixing it up. It's similar to what I'm about to show you. The story remains the same. Now, understand, one more thing I want to tell. We don't know if the patient took the oil, because they may be just saying, I took it, and I got my $25. We weighed all the, before giving it to them, before dispensing, we knew how much weight was in those bottles, and we already knew that at day 1, day 2, day 3 usage, how much weight's going to be gone. So we validated when we got that back. Number 2, we also evaluated the blister pack. So if someone told me, oh, I started using it, I don't know, and if you use nothing of it, then it's not true. So we had internal controls, try to validate some of the things, and that was that. I'm going to quickly jump to them and move it through. Appreciate the idea. Now, of course, pain is subjective where it starts from, But look at this. So if I took about 2 hours interval, about 8 to 10 hours, I will probably be in the interval about 1 day, right? So what you see, the CBD oil alone, the higher dosing, you literally saw, so this is when they had their surgery, post-surgery. So after their surgery is done, guess what they have? They're numb. The lidocaine probably did its job, they're not good. And as they move out, they start to move into pain again, and they start taking the medication, and what you end up seeing with the higher dosing was you almost flatline them. Right? So that's what the data we got in terms of that. Now, again, I did not normalize the data to a percentage, which may have helped more, because I could basically make them all equal to a percentile of what they do. But I did not do that at this point. On the other note, I wanted to show you, this is my, so let's start with the gray one. I don't know, bluish gray, greenish gray, I can't tell color nowadays. But here, what you see is people stop after 13 minutes because that was a placebo. So you expected that they would notify you when they say, hey, there was too much pain. I have to take something else. So this actually shows the true effect of placebo as well. It was not helpful. That did not do any true pain management. The patient will reduce it. The lower CBD was, the unique part was, initially it didn't do much. But later on we see an improvement, but it may be too late. The crazy part, however, none of the CBD low group, even though they technically reported high pain, decided to take the treatment as usual. They didn't take the blister packs. I have no group. That's not mine. It's their choice. But normally we'll say, if you're still in pain, go take it. They're like, oh, it's still bearable. And they decided not to take it. So whatever the case it was. As you see, the treatment as usual, which is this green, if you will, which is right there, starts at 2, goes up, stays a little bit, and you can see ibuprofen and Tylenol kind of bringing the pain up and down in 2 data points. That's where we're at. Okay? So generally speaking, the study kind of showed that we actually could use CBD as a mechanism. We're going with NIH grants, hopefully soon, with all the data that we have, to show this, that it works. The general idea here is that higher dosing actually works. It may rival that of normal ibuprofen Tylenol combination. We have basically dosing parameters that we need to figure out where is that low, where is that cutoff, where it does not become helpful at all. So there's going to be more patient groups. There's also things that I mentioned to you, the terpenes and flavonoids. There is something called the entourage effect with many of these cannabinoids. What that basically means is when lipids are with other lipids, they sometimes increase the propensity of reaction. So they say in these hemp oils, when they use CBD or other things, it actually helps more to get that response that you want. So that's one thing that we may also introduce into the problem. But the general idea is our studies seem to show the same trends that we see in rodents or animal studies altogether. All right. So anyway, the general idea is we're going to continue on the larger study for the CBD population. We're going to go back and look at some of the underlying pathways, also co-treatment concepts. After we have well-designed things, can we do co-treatments? Did it show a synergistic effect? And we improve that altogether. Okay. That is my information if you need it. I'm sure your office will provide whatever is needed in terms. I have a bunch of citations. I don't want to pull all of them. But that's basically it. If you have any questions, I don't know how, did I overgo my time? I always do the same thing. We have time for a couple of questions. If there are questions, I'll be happy to answer whatever I can.
We got one over there.
Yes, please.
Okay, explain to me, like on 5, the difference between NSAIDs and CBD.
Okay, so it's very difficult to say as a 5 because I don't know if they understand the body's molecule altogether. So, but the general idea is this: if I were to give, whenever I have inflammation or any type of pain going on, what our body does is to recruit the immune response. I know this is not a 5-year response, but I'll try my best. Whenever the body needs to fix itself and say, hey, let's do a cleanup shot here, I need the right mechanics, the right machinery, policing effects, if you will, which are the immune cells. So they need to come across at that area. When they kind of come together, some of the substrates they're produced, which I was mentioning, prostaglandins. When they produce that, that is also the body saying, hey, don't touch this, I'm fixing this. When I press it, it starts to hurt, right? So don't hurt the boo-boo, I guess. So, so at this point, we don't want to have that happen. So what the NSAIDs do is they actually reduce that production of that prostaglandin, right? Cannabinoids seem to do the same type of thing. And because they're all, I mean, the cannabis-based plant is a lot of lipids, and the arachidonic acid pathway is all lipids as well. So it's part of a lipidolent, and now I'm using the fancy word, lipidolent score. So where you have lipid-based signaling happening, which actually improvises different parts of your body. In this case, NSAIDs can do very much similarly what something like a CBD or CBDN, or basically non-psychotropic that would do. So we can actually use them as also pain management tools altogether.
So the same GI effects?
The GI effects may not be as much because there is a different distribution of how it's taken up. So when the constitutive activity of COX-1, for instance, from the GI, is kind of different from because those are selectively targeting that specific enzyme. In this case, the distribution because of lipid or oily, they go as like emulsifying agents that kind of propagate all through differently altogether. So generally, it's not going to be that, but if you overly intake that, I'm sure it could have some GI issues. The problem with cannabinoids, however, since we brought to that point, which I did not mention here, CBD and a few others, because they are lipid in nature, you take them for 3 months or more, and the study of epidiolex has shown that you actually have liver problems, the ALT, AST increase. It's the same thing as being fatty, like a fatty liver concept. So it's the same type of things that happen over there. But I'm sorry, I can't go in, after giving this, I can't go into baby mode. So I have to, I have to go back. I do have kids, so I do explain things. The moment was not, so yeah. But yes.
So there's obviously a lot of parallel research on the medical side of the house with CBD and THC.
Correct.
Are you able to apply some of the pre-existing research to the work that you're doing specifically with dental medicine?
So yes, there is. So remember, this is what I was mentioning. We do not understand what route is best for what purpose, right? So if I wanted an immediate effect of cannabis, holistically speaking, for pain or just getting it high, smoking is probably the best way to go. It goes right into your bronchial, right into your bloodstream, it goes right into your CNS. It's very quick. By the time you eat, as we were talking about the liver perspective, you ingest it, it has to go through your portal vein system, goes through your typical first pass metabolism concept. So it goes there, breaks it down, whatever it needs to break down, absorbs some areas, and then it goes into your distribution. If it is fatty in nature, many times it gets picked up and it goes into adipose tissue. So that's why, I don't know if you all have tried edibles, but general idea is some people who can try edibles, they won't get an effect right immediately. Sometimes they do. Many times, majority of times they don't. So like, I'm waiting, nothing's happening. And so that's the principle back there. And same thing happens is because they're lipid, so not telling you all information, just giving what the real science is. The reason why people use, when they make cookies or so, why they put it in, they have to put it in butter or lard or some other form, is because if you actually have a fatty substrate along with CBD, that fatty substrate is more likely to be picked up by adipose tissue, and therefore you have more blood volume of this fatty itself. So basically what I'm trying to tell you is, if you want to make a cookie, make it a lot of oil into it. So the pharmacokinetics has changed based on these oil presentations. So if you have a high fatty diet and you take cannabis or consume it, you'll get a better high. Sorry. Same science.
And I apologize, it was the first half, the first part of this, first in Starbucks, not worth it. But, so my question is, what's your patient questions? Did you do any pre-screening to see if anybody, if your users were current users of other cannabis products? There's a lot on the market, topicals, etc.
So we did have a question on the questionnaire just to get that information, because
Was that an exclusion?
so we did. So any chronic was an exclusion. Anyone who uses it here and there, we did not. Because one of the things I'm seeing more and more in clinical practice, to be very honest, which is a very much concern, because many universities right now for dental schools, and I think Creighton also has the same policy, which I disagree with, but it is what it is. If you're smoking and you get on there, like, you know, high or potentially high, and they get to know that they were smoked and they came to your appointment, because of liability and because of getting a consent not truly signed, people don't see that. They will say, hey, go away when you're done. The problem comes to me from that is a common smoker, chronic smoker is different from someone who's just recently used it. So if someone just started, how long ago did you use it? I have a concern with it for cardiac events or other things of that sort. So I'll tell you, hey, come back, it's elective care, let's not do this right now. Unless it's, you know, excruciating pain or something, we have to do something, different story will optimize a different sign and so on. But many schools don't even want to take those patients because they don't know what to do with it. And so that's the dialogue that we have going on based on your question, is at some point, if the patient is a user, has that changed the distribution of receptors throughout your body because you have accumulated a response to it. So do I have to be eating less or more? You don't know. And those variables matter in terms of that. And the crazy part, just to add to, in the pharmacological perspective of cannabis, when you use it, actually in the drugs themselves, it has a weird, it's not a dose, it's a U curve, meaning low response, and then there's no response, and there's high response at a high dose, and again, it's weird because of lipid dynamics altogether. So,
and just follow-up question on lipid dynamics. And I haven't seen a lot of research on this, difference in patient response based on gallbladder or no gallbladder, and the ability to break down bile salts and fats. I haven't seen a lot of research on that, but any, do you know?
so I did two patients that we, and this is again arbitrary. It's not research. This is getting to know the patient. The anecdotal perspective. People who had gallbladder removal had no problem processing. They actually got a better high, to be really honest, based on what they told me. So I'm like, yeah, I'm doing it. I have pain on my back. It works great. I'm like, okay. But, you know, it's interesting. The norm today, about 5 years ago, patients weren't as open about talking about it. Now, people will ask, if you ask the right question, they'll openly tell you. So, which is a good thing for us as practitioners because you want to know where you're about to get into. Because me numbing some of these patients, it takes more numbing capacity. Chronic use, everyone intermediate and so on, not so much. So, but if you are random users, please maintain your health, oral health, because eventually it means other problems coming from you as well. Because the majority of the people who use it, they basically are eating more, having a cotton mouth, or dry mouth, whatever you want to call it, and then basically, majority of them don't clean their mouth at the time of. So you are propagating the problem. So oral hygiene matters.
That's all the time we have.
All right, excellent.
Thank you so much.
I was trying to make sure I don't.